Bismillahirrahmanirrahim. Today I'll be talking about the emerging role of endohepatology in chronic liver disease. The term endohepatology was coined by Chang Kenneth in 2012, and essentially it means the assessment and management of the liver through endoscopy. Hepatologists increasingly have been turning to radiologists for liver imaging and interventions. However, it would be most ideal if the assessment of and treatment of liver disease could be performed and assimilated by hepatologists themselves. We all do some sort of endohepatology. We do it by the assessment of varices. We do therapeutic endohepatology by band ligation of esophageal varices and glue injection of gastric varices. However, with the addition of endoscopic ultrasound, a new dimension has been added to endohepatology. Endoscopic ultrasound basically means the combination of endoscopy and ultrasound scan capabilities to enhance the diagnostic and therapeutic abilities. So today I'll be discussing these aspects of endohepatology. So I'll be discussing the elastography and contrast enhanced EUS roles. I'll be discussing EUS guided liver biopsies and the assessment of ascites and paracentesis, portal vein pressure gradient measurements, and EUS guided coiling of gastric varices. So the liver assessment can be done through an echoendoscope. Transabdominal ultrasound scan is the usual first-line imaging modality because it's cheap, non-invasive, and no radiation exposure happens. However, focal liver lesions can be missed with transabdominal ultrasound scans, especially if they are less than 1 centimeter. EUS has a high diagnostic yield in detecting these very small liver lesions, but EUS has its limitations as the examination of the liver through EUS is incomplete. Elastography basically assesses the stiffness of various tissues. The stiffness of the tissue depends on the density of it, and the stiffness affects the speed of sound when it passes through it. This ability is detected by the ultrasound scan, and various color coding is given to the stiffness of the tissues. Blue usually means hard tissue, whereas red means soft tissue, and this ability can be used to detect various tumors. So promising data is emerging with regards to shear wave elastography, which is being introduced in EUS. EUS guided elastography can help discriminate between benign and malignant tumors with a sensitivity of up to 92.5%. However, as always, tissue remains the issue, and even with elastography being so sensitive, we still can't rely on it completely, and we need to attain tissue for final diagnosis. However, elastography can be used to target which tissues to biopsy. So for example, in this case, the patient had pancreatic cancer with liver metastases. The metastases are not very clearly visible on B mode ultrasound scan. However, when elastography is performed, the hard areas suggest areas of metastases which can be easily biopsied and targeted. Another aspect that can be used in EUS is contrast enhanced EUS. Various contrast agents containing microbubbles can be used to assess the perfusion of higher accuracy for detection of left lobe metastases compared to B-mode EUS and multi-detector CT scans has been shown with contrast-enhanced EUS with an accuracy of diagnosis of up to 98.5%. EUS-guided contrast-enhanced tissue-guided acquisition has excellent diagnostic accuracy even in cases of very small lesions. In this example, a B-mode EUS is being performed in which the lesion is barely visible. However, with contrast enhanced EUS, the lesion lights up, which can assist in making the diagnosis. Next topic that we will be discussing is EUS guided liver biopsy. So liver biopsy is the gold standard for diagnosis and staging of liver diseases. Traditionally, this has been performed percutaneously, transjugular route, and surgically. However, US-guided liver biopsy is emerging as a new technique. It was first described for liver masses in 1997, and then the routine use of US-guided liver biopsies was reported in 2008. Now, there are various considerations regarding liver biopsy specimens. ASL suggests that the specimen should be more than 2 centimeters in length and have at least 11 complete portal tracts. The specimen quality should be good with minimal amount of fragmentation and architecture loss. Whatever route is used, it should be safe, and the lesion to be biopsied should be accessible. US-guided biopsy is a relatively straightforward technique. A 19-gauge needle is used. Usually the left lobe is accessed through the GOJ, whereas the right lobe can be accessed through D1. The area to be biopsied is identified under direct vision. Vessels are avoided and the needle is inserted. The key thing with US-guided liver biopsy is the withdrawal of the needle. When this is performed, if there is a Doppler signal in the tract, then that suggests bleeding, in which case the withdrawal can be withheld until that bleeding stops before the needle is withdrawn. This the technique then reduces the risk of complications. A meta-analysis done by Mohan in 2019 suggested very good results with the US-guided liver biopsy. This particular study contained 9 study arms with 437 patients with an overall diagnostic yield of 94% and a 2.3 pooled adverse events with a 1.2% pooled bleeding event risk. People have tried various needle types and suction techniques to optimize the yield for liver biopsies. The various needles that have been used include true cut biopsy needles, straight needles, reverse bevel, and shark core. However, this meta-analysis suggested that a 19-gauge FNA needle provides significantly better biopsy specimens. The thing to remember, however, is that this meta-analysis was done on studies that were conducted between 2009 and 2018, and since then newer needles have come out, and therefore the choice of needle is evolving for liver biopsies. Various suction techniques have been described with US-guided FNA and FNBs. These include dry suction, slow pull technique, wet suction, modified wet suction, wet heparin, and dry heparin. All of these techniques can be used while taking biopsies. None of the studies have suggested one technique being better than the other. I'll just show a small video which demonstrates the technique of US-guided liver biopsy. In this particular case, a 19-gauge needle is being inserted into the liver. A slow pull technique is being used to create negative suction to attain the biopsy. As you can see under direct vision, the vessels are being avoided. Another technique that can be used is the modified wet heparin technique. In this case, the stylet is removed and the needle is filled with heparin. A column is made. Following that, another syringe with 2 mils of saline is attached and suction is applied. The tissue is once acquired into the needle can be expressed by placing the stylet back in, and this is how an EUS guided liver biopsy looks like. So the specimen characteristics have been compared in various studies. With regards to percutaneous liver biopsy, the portal triad on average are between 9 and 15, with a total length in millimeters of 15 to 27. With regards to transjugular biopsies, the portal triads are usually on average 6 to 20, with a total length of 15 to 27 millimeters. With EUS-guided liver biopsy, the portal triads are higher, with 10 to 24 portal triads, with a total length of approximately 23 to 49 millimeters. So this slide basically shows the comparison between the three modalities. There are certain advantages of EUS-guided liver biopsy. It provides the ability to perform simultaneous bilobar biopsies, with the left lobe being accessed through the GOJ and the right lobe through the duodenum. It circumvents challenging body habitus such as high BMI, etc. There is improved patient tolerance and decreased recovery time with the EUS-guided liver biopsies. And also EUS provides the ability to perform other diagnostics simultaneously, for example, portal pressure gradient measurements, varices assessment, etc. There are, however, certain disadvantages of this procedure, including high cost of the procedure and the need for technical expertise. Now moving on to EUS-guided paracentesis. Small amounts of fluid, as little as 2.7 mils, can be aspirated, yielding valuable diagnostic information in patients with a mental caking and thick peritoneal deposits. An EUS-guided approach can be easily performed to access otherwise pockets of fluid that would be challenging to drain by the transabdominal approach. So again, a little video showing this procedure. This particular patient was post-liver transplant and had developed COVID. Following that, he became septic, and the scan suggested a large collection in the subhepatic area. This particular collection was not accessible through IR, and therefore an EUS-guided aspiration of this fluid was performed. The area of interest was identified through EUS. Access was gained with a 19-gauge needle. And bile stain fluid was aspirated. These images are from post-aspiration, suggesting the cavity is now collapsed. So EUS-guided paracentesis is generally safe and carries little additional risk. Bleeding is a potential risk, and therefore it should be avoided in coagulopathic states. The risk of infection with self-limiting fever is up to 3%, whereas the risk of developing significant bacterial peritonitis is as low as 0.04%. However, there is additional cost with EUS-guided paracentesis, and also this technique is not available in all centers. Moving on to EUS-guided portal pressure gradient measurements. We are all aware that the gradient is calculated by the portal vein minus the hepatic vein pressure and reflects the degree of portal hypertension. It is one of the best prognostic factors for survival risk and of decompensation. A portal pressure gradient of 10 millimeter of mercury points towards the presence of varices, HCC, and post-resection decompensation. A level of up to 12 millimeter of mercury is associated with variceal bleeding, and a higher pressure gradient of 16 to 20 millimeter of mercury can suggest additional decompensations and increased mortality. Traditionally, the hepatic venous pressure gradient has been measured by IR, with measuring the portal, the hepatic vein pressure, and then wedging the balloon in the hepatic vein, which gives an indirect measurement of the portal vein pressures. In EUS-guided portal pressure measurements, a needle is inserted directly into the hepatic vein and pressures are obtained. The same needle is then inserted into the portal vein to directly obtain the pressures. So a little video demonstrating this technique. It consists of a small portable barometer that is attached with a flexible tubing to a 19-gauge needle. a syringe containing heparin is attached on the other side of the barometer. The barometer is kept in the mid-axillary line, and then access via the 25 gauge needle is made to the hepatic vein. The pressure increases initially and then stabilizes, and this is noted. The key in this case is the removal of the needle, as shown in this video, in which the tract is identified under Doppler to see for evidence of any bleeding. The portal vein pressure is then measured with a similar technique, and the gradient is then calculated. So the 25 gauge needle, which is a smaller needle, is used for this procedure. It's a very simple and portable setup. There's no need for fluoroscopy or contrast in this particular procedure. You can directly measure the pressures rather than wedge hepatic venous pressure. There's excellent correlation with clinical parameters of portal hypertension as well as IR-guided hepatic venous pressure gradient measurements. There are other interventions that can be done through EUS in patients with chronic liver disease on the portal vein. So for example, patients that present with portal vein thrombosis, in which occasionally it is challenging to identify whether they are bland thrombosis or tumor thrombus, simple EUS guided FNAs can be performed in the extrahepatic portal vein to clinch the diagnosis. EUS guided portal vein sampling has also been described for circulating tumor cells. There's some preliminary results in an animal model regarding EUS-guided embolization with coils of the right portal vein. And also there are animal studies regarding the placement of intrahepatic portosystemic shunts via EUS. Moving on to EUS-guided coil placements for gastric varices. So Levy et al. First described EUS-guided placement of the coils with glue. The rates of systemic emboli was significantly lower in the coiling group, and therefore it was suggested that the EUS-guided placement of coils provided certain potential advantages over the glue, with the additive effect of hemostasis, reducing the volume of glue needed for obliteration, and also the coil acting as a scaffold to retain the glue within the varix, thus reducing the risk of systemic embolization. These are some images of EUS-guided coiling of gastric varices. The top left suggests the varices, followed by the varices being identified in the Doppler. The coil was placed, and the bottom images show how the endoscopic view looks like after the coil placement. So in summary, endohepatology is here to stay. At the moment, EUS-guided liver biopsies are being performed. Coiling of the gastric varices, portal pressure measurements, and aspiration of ascites is also being performed. In the future, EUS-guided elastography and contrast-enhanced EUS will have a role in the management of patients with liver disease, as will EUS-guided intrahepatic portosystemic shunting and portal vein sampling. There are just a few points to remember. At present, radiology continues to remain the main cornerstone. There's an argument regarding cost and cost effectiveness of these procedures, as the cost of doing EUS-guided procedures is high. There's an element of training as well for these particular procedures, and then there's a mental barrier for the physicians and the surgeons to overcome before these tests can be accepted routinely. Thank you.